Welcome to Pathways, Becoming Trauma Responsive, where we explore trauma through a compassionate lens, discover how these experiences affect each of us differently, and dive deeper into what it really means to become more trauma-informed. I'm your host, Dr. Elizabeth Meeker, Senior Director of the New York State Trauma-Informed Network and Resource Center, funded by the New York State Office of Mental Health. The network advances the collective understanding of trauma, wellness and healing, and trauma-informed practices in action. This podcast is produced by CCSI. The views, opinions, and content expressed in this podcast do not necessarily reflect the views, opinions, or policies of the New York State Office of Mental Health or CCSI. This is a special edition of Pathways, where we travel outside of New York State to hear and learn from national experts. Well, it is my pleasure and privilege to be welcoming Nadine Burke Harris to Pathways, Becoming Trauma Responsive. We are so grateful to have you today, and really just wanted to say first, welcome for being here.
Oh, thank you so much for having me.
I would love to hear, you've had many, you have many roles as the first Surgeon General of California, pediatrician, author, I think in all of those roles, you've just played such a pivotal piece in bringing awareness around ACEs to the forefront. For many, the science was there and it was kind of like almost hidden behind the curtain. And, through your platform, you were one of those people who really helped to advance the awareness. And so I would love to hear a little bit just about your journey to discovering about ACEs and childhood trauma and how it's played a role in kind of your work.
Absolutely. It's really interesting. I did not learn anything about ACEs or toxic stress in medical school or residency. I certainly learned about child maltreatment, but I did not, even though the ACE study was published in 1998, I graduated medical school in 2001 with really just, it was not incorporated into what I learned or what I learned in my residency training. But so really the way that I came to learn about it was in starting a practice in a very low income underserved neighborhood. Mm-hmm. And I really came to it focusing on health disparities and trying to ensure that every child has equal opportunity to grow up healthy. And as I was caring for patient after patient after patient, as I was getting to know families and as I was doing as I say, doctors are trained to get a history and physical. Mm-hmm. And we learn that the history part is oftentimes more important in terms of helping us understand what's going on with the disease process than the physical exam. And what I was hearing in that history was just so many of the kids that I cared for were experiencing serious adversity. Having a parent who is substance dependent or a parent with an untreated mental health condition. And there was one patient I was caring for who had asthma. And I had, put her on a couple rounds of really powerful anti-inflammatory medications to try to keep her out of the hospital. And when I sat down with her mom to say, are there any asthma triggers that we could be missing? Is it pet dander, or there's no cockroaches, we got an air filter, like what are we missing? And I will never forget what this mom said to me. She said, doctora, I notice my daughter's asthma acts up every time her dad punches a hole in the wall. And that for me really got me looking at the link between how kids' experiences and environments shape their biology and increase risk of disease. So that really is what brought me to the ACE science and beginning to look and say, how does this all fit together?
Yeah, thank you for sharing that. I always think about it's like that aha moment so many of us have had when we discover about the ACEs science, and suddenly things start to make a lot more sense, I think, than they did, as you kind of shared in that story. Um, so I'm just wondering, for some of our audience, they may not be as familiar with ACEs science, and I was wondering if you could just take a few minutes to kind of briefly kind of share a little bit about the science and how it is related to health, and and some health disparities as well.
Absolutely. So what we understand is that the landmark study that really shone a light on the link between early adversity and lifelong health outcomes was a study called the Adverse Childhood Experiences Study, and it was conducted by the CDC and Kaiser Permanente. And in it, they asked 17,500 adults about their histories of adversity in childhood. And these included 10 categories of what they called adverse childhood experiences. And those include physical, emotional, or sexual abuse, physical or emotional neglect, or growing up in a household where a parent experienced a mental health disorder, where a parent was incarcerated, where there was parental separation or divorce, where there was intimate partner violence, or parental substance dependence. So those were the 10 traditional ACEs. And what they did was they looked at the association between these 10 adverse childhood experiences and health conditions. Because this is Kaiser, right? Like they have their medical records, and it's
Right.
like 17,000 people is a lot of people. Like, it's not like it's 100 people where you're like, oh, is this a real pattern?
Right.
And so what they found was really striking. There were two things that they found. Number one, these ACEs that I just described are actually incredibly common. So 2/3 of folks had experienced at least one, and 1 in 8 people had experienced 4 or more adverse childhood experiences. So that was kind of the first thing where it's like when we think about some of these hardships, oftentimes folks think, oh, they're only happening in certain places or in certain communities, or there are many people who feel like, oh, it only happened to me,
Right.
right? And then what the ACE study really showed is that they're actually incredibly common. The other thing that they found was that there was something called a dose response relationship between these ACEs and adverse physical, mental, behavioral, and relational health outcomes. So, for example, when we say dose response relationship, that means the more categories of ACEs a person has experienced, the greater their risk for these different health disorders. So, for example, a person with 4 more ACEs has double the risk for heart disease, 2.5 times the risk for chronic lung disease, more than double the risk for autoimmune disease as compared to a person with 0 ACEs. When we look at conditions, health conditions like depression, then we see a person with 4 more ACEs has 4.5 times as likely to develop depression over the lifetime as compared to someone with 0 ACEs. And what we now understand is that since that original study, there have been thousands and thousands and thousands of other studies that have not only corroborated the findings of the ACE study, but also helped to fill in the dots around how this happens. And so what we now know is that when we experience high doses of adversity in childhood without adequate buffering protective systems, can lead to a change in the biological stress response. And it leads to prolonged activation of the brain and body stress response that can actually, these high levels of stress hormones like adrenaline and cortisol can actually change the way a person's brain develops, right? So childhood is this time where we're really malleable, right? We're really, our influences actually have this really big effect on how our brains and bodies develop. And so we see changes in brain development, development of the immune system, the hormonal systems, and even the way our DNA is read and transcribed. And so those changes, the prolonged activation of the biological stress response, and the changes to brain, immune, hormone, and genetic regulatory function is what doctors now call the toxic stress response. So that's what we know. Yeah.
Yeah. And so I can see why you said earlier, the importance of getting that history is so critical, because the symptoms could just, there's so much underneath the surface that could then determine the course of treatment that's really appropriate.
That's exactly right.
So, I am curious because you mentioned the 10 ACEs, and I think since that pivotal study, we've also really expanded our understanding of what adversity is, or what can compound those, the 10 original ACEs. So, I'm wondering if you could reflect on that and how that's informed your work as well.
100%. So one of the things that's really interesting is that, and a question that I get a lot is like, oh, and aren't, what are the other ACEs or the new ACEs? And I make a distinction that I think is really important, is that one of the things about the ACE study that has made it so powerful was, in the original study, they looked at it in 17,500 people. And like I said, there's been a lot of research that has replicated these findings. So typically when we talk about ACEs, we're talking about the 10 traditional criteria. But what we also know is that there are other risk factors for the development of the toxic stress response, right? So experiences like discrimination, like severe poverty, having experiencing the atrocities of war. These things can also lead to a prolonged activation of the biological stress response in a way that disrupts brain, immune system, hormonal, and genetic regulatory development. I think it's important to make the distinction that, like, when we say if an individual has 4 more ACEs, we need to know what things we're talking about, because if we're saying, for example, that you have an individual with 4 more ACEs has a relative risk of ischemic heart disease, that is, 2.1, right? So we have that data from very large data sets. That's the reason why we don't necessarily call those other factors ACEs. But the important thing is we understand that they are risk factors for the development of the toxic stress response. And the reason that's important is because the other thing, which is my favorite part of this, is that the science is showing us is that toxic stress is treatable, right? So this activation of the biological stress response, there are ways to regulate the biological stress response. There are ways to regulate the inflammation and the hormonal disruption that is a result of this prolonged activation of the stress response. And some of those things include things like, my favorite is always safe, stable, and nurturing relationships. That's so foundational. But also we see things like meditation, like, mindfulness practices can also regulate the stress response, reduce the activation of our sympathetic nervous system, which is fight or flight. Some say fight, flight, or flee, right? And then and it will help to increase the nervous system that helps to counteract that fight or flight response, which is our sympathetic nervous system, which we refer to as resting and digesting. So it helps to calm. It lowers heart rate, lowers blood pressure, reduces inflammation. And so we see things like good sleep hygiene, and having healthy sleep is also really important for regulating the stress response. So this is where I get really excited about this science, because ACEs have been around. In my book, I think I make the joke that ACEs have been around since God was a boy, right? Like long time. But what understanding the science of ACEs and toxic stress allows us to do is be more precise and targeted in identifying what the challenge is and then also responding.
Yeah, absolutely. And what I hear as you're talking is just so much hope. I know when I talk to people and they ask what I do and I talk about working in the field of trauma, there's like, ooh, that must be really hard and heavy. And there's aspects of it that are, but I also find there's just so much hope because as you're talking about, when you understand the science, it points you in the direction of what you can do to mitigate the impact.
100%. So let me give a very concrete example. One of the things that actually kind of tipped me off that there was something that I was missing in my own clinical practice was I was being referred a lot of kids for ADHD or attention deficit hyperactivity disorder. And, I had started this practice in this very underserved neighborhood called Bayview Hunters Point. And so kids were coming in to see me and had been diagnosed with ADHD and they were on, one of the standard first line therapies for ADHD, Ritalin or Adderall, or, something Concerta, something along those lines. And it wasn't working. And so then a very well-meaning clinician would say, wow, this kid is having all these really disruptive behaviors. They can't sit still in the classroom to learn. So we're going to add in some additional therapeutics to help to kind of regulate their behavior. And so they'd be on Ritalin, and then they'd be sometimes on an antipsychotic, and sometimes, right? And it was very clear when I looked at it in my practice that I had some the patients who tended to have ineffective treatment with first line ADHD meds were also the ones where that history part had the most challenges and adversity at home. And this is where like the fact that I'm a super science nerd totally comes in, because when you look at the science of the functioning of the prefrontal cortex, which is the part of the brain that's responsible for executive functioning, it functions in an inverted U, right? Like, and so with relationship to stress hormones like adrenaline, right? So if you don't have enough stress hormones, they're called catecholamines, but if you don't have enough stress hormones, you can't focus. And so you're distracted, disorganized, forgetful, and impulsive. That is what ADHD looks like, okay? And that is the reason why Ritalin is the number one treatment for ADHD. It's not like anyone just throwing meds at people. Like there's a real scientific basis for it. And so as you add a stimulant, you see improvement in the functioning of the prefrontal cortex. But the problem is if you add more stimulants and more stimulants and more stimulants, you'll see a decline in executive functioning. And it's a little bit like if you drink 1 cup of coffee, you can focus. But if you drink 20 cups of coffee, you can't focus to save your life. Right? So for many of the kids who I saw were on multiple medications, right? When I did an ACE screening as part of my routine clinical care, what I found that if a patient had 6 ACEs, chances are the problem is not, yes, the prefrontal cortex is underfunctioning. Yes, they're distracted, disorganized, forgetful, and impulsive, but it's not because they have too little stress hormones in their brain. It's because they have too much. So I, in my clinical practice, worked with a consulting psychiatrist who would change them. So it's not that we didn't use medication. So it's not one of those things that medicines are bad. The medicine has to target the physiology. So we would actually change them from being on a stimulant and an antipsychotic and sometimes some other medications to being on a medicine that targets the stress response. And so we often use a medication called guanfacine. We would bring our patients down from, 2 and 3 and sometimes 4 medications to 1 medication. And these kids would come, they'd bring in their report cards going from failing to being on the honor roll.
Wow.
Right? So that's why understanding the biology of stress and the impact on the brain really affects our treatment decisions. Now, I want to be clear, right? That medication part is only one part, right? The other part of it is helping to support that family with safe, stable, and nurturing relationships. And I'll say that if I have a 10-year-old who's got 7 ACEs, really understanding, helping to support the parents or caregivers, because what I've seen is that it's almost universal intergenerational transmission. And so really helping the parents and caregivers to understand how they can regulate their own stress response, right? To then help create that safe and stable environment for kids.
Right. Oh, so much good stuff there. Just really thinking about that precision of the treatment, and again, tying back to the science and understanding that. But, I think that the thread around those safe, nurturing relationships and the importance that they play. And, I'm curious about educating families around ACEs and how you've gone about doing that in your practice, or how you might recommend that to others.
So one of the things that I like to do in my approach, and just to be clear, in my role as California Surgeon General, we launched a first in the nation effort to train healthcare providers on how to screen for ACEs and how to respond with evidence-based trauma-informed care. So California has trained more than 43,000 providers since 2020. Since January of 2020. So there's a lot of resources, and if anyone's looking to learn about this, they can just go to acesaware.org. And the training is free, and so it's available. But one of the things that we put in ACEs Aware, built in as part of the curriculum, and that is really fundamental to the approach, is really doing the assessment and education in a really strengths-based way and a really supportive way. So a couple of the things that I like to do, say to families is, and there are even, I think, scripts included in the ACEs Aware training, is that I often like to say, because of what you've experienced, your body is maybe making more stress hormones than it should. And that can look and feel like being quick to anger, or getting sick easily when you're overwhelmed, or having trouble controlling your impulses. And then just like check in, and does any of that feel familiar, right? Most often, what I find is like, yes. In fact, the number one reaction that I have received in my clinical practice was, "Oh, you mean I'm not crazy?"
Yeah.
And I think that for many providers, the fear can be that if you talk about the impact of ACEs, that it can be, people can feel like they're broken, or it can be kind of, I think sometimes I hear from folks that, oh, it feels deficit based. And my own experience is the opposite.
Yeah.
Over and over and over again, what I have gotten from families, and I think it is important to take a strengths-based approach, to say, hey, you know what, your body, that's your body's way of protecting you. That's actually a normal biological response to the things that you have been through, right? But one of the things that can happen is that can continue to happen in ways that are not so helpful later on down the line. And the good news is there's lots that we can do about it.
Thank you for joining us today. Please visit our website, traumainformedny.org, for additional trauma-responsive resources, events, and training opportunities. Subscribe to our podcast to be notified when our next episode is released.